I'm so happy to have Dr. Kelsey Harris with us. She is our audiologist that is both in Fort Collins and our Westminster offices. And I wanted to have Dr. Harris on the podcast today to talk a little bit about an article that was featured in the Hearing Review last May. And the title of the article was Cognition, Audition, and Repeated Cognitive Screenings. And the interesting thing here is Dr. Harris did her capstone research project in graduate school on cognitive screenings in audiology. And so it's relevant because a lot of people with tinnitus also experience hearing loss, right? Something like, what do you think the current number? We think Dr. Harris is 80%, 90%, something in there of people with tinnitus have hearing loss?
I would say more like 90%.
Yeah. It's the vast majority of people, we could say with confidence, have changes to their auditory system, specifically to the inner ear, to the hair cells in the inner ear that leads to less clear input being delivered to the brain. And now we're seeing connections, right, between untreated hearing loss and cognitive decline. And this is a big concern, right? Because Alzheimer's is a health epidemic, something that a lot of people are very concerned about because we're living longer, but we want to make sure with living longer, we have the quality of life and trying to avoid as much cognitive decline as possible. So can you tell us a little bit, Dr. Harris, about some of the background, some of the studies maybe, or information that's been recently brought to our attention about some of the links between untreated hearing loss and cognitive decline?
Yeah.
What's been out there?
Hearing loss actually is the top or number one modifiable risk factor for hearing or for cognitive decline and dementia. So there's studies that show even mild hearing loss can actually double the risk of cognitive decline. Moderate hearing loss can triple it, and severe hearing loss can actually increase it by fivefold. So the evidence is there. The evidence is there showing the link between the two. The theories on why, not concrete, but there's a few well accepted theories about why the link is there.
Yeah.
And so one of the most commonly known or thought of reasons is the reason for social isolation. The fact that people with hearing loss tend to not engage in social activities. They start kind of reducing their just social engagement altogether because of the hearing loss specifically. So that in itself can lead to reduced cognition, I guess, in general. So there's one theory. Increased cognitive load really is meaning that the additional resources to decode the auditory signals may deplete the cognitive reserves. So your brain is just working harder altogether to having to understand or work hard to understand speech. The other is kind of the opposite, is that with hearing loss, it's almost kind of a use it or lose it type thing, where if the brain isn't getting auditory stimulation and actually will reorganize in the brain, and so that in itself reduces or increases brain atrophy, or essentially shrinking of the brain.
Right. And none of us want to see our brain shrinking as we age, because that can only lead to negative outcomes, right? So when we say most modifiable risk factor, how do you interpret that? Because I think that we can unpack that a little bit.
Yeah.
So when we say modifiable, what exactly do we mean?
That means things that can be changed, lifestyle changes. One of the things that increases risk is genetics. We can't change that. However, we can change things like treating our hearing loss or treating diabetes, reducing alcohol and smoking, things like that, which we can actually change versus unmodifiable things that we can't.
That we have no control over, right?
Exactly.
Yeah. Yeah. And why would we want to change those things earlier rather than later? I think a lot of people think, oh, well, my hearing loss isn't that bad, so I'm not going to do anything now. Why is that probably the worst kind of thing you could do for yourself?
Yeah, because once the process starts, you can't really get that back. So, because there's such a limited treatment for cognitive decline and dementia, that being proactive in early identification and early treatment is really the number one thing you can do.
Absolutely. Yeah. Yeah. And especially, I think a lot of people are um, reading this research or starting to believe what they're seeing because multiple studies, longitudinal studies, the Lancet study, or Lancet report, the Achieve study by, a lot of people have heard of Dr. Frank Lin from John Hopkins and his group, Pike, Albert et al. I think more people are coming in saying, hey, dementia and Alzheimer's runs in my family. I want to do everything in my power to avoid or to slow down that possible diagnosis. What could I do? If you have hearing loss, you could treat the hearing loss right away, even if it's mild.
Mm-hmm.
And I mean, we see it all the time, right? Dr. Harris, people coming in with mild hearing loss and saying, "Oh my gosh, I didn't realize, how much I was struggling. This is so much easier for me. I didn't realize all the sounds I was missing." What are other things people tell you, even with mild hearing loss, when we treat it early?
Yeah, even things just overall less listening effort. So some
Hmm.
people will even say, I feel like I even have more energy because I didn't realize how much I was actually filling in the blanks of things
Hmm.
that maybe you're missing here and there, where your brain's just working harder to fill in those
Hmm.
blanks when you're not catching all of those little details of speech.
Hmm. The subtle cues, right?
Mm-hmm.
The differences between like S is in sat, F is in fat, a TH with those high frequency sounds, they start to blur, they start to blend, they start to get distorted. And then, yeah, your brain has to use more of its cognitive powers to say, wait, did she just say the baby is very fat or I got a new cat? And then trying to use context and visual cues and facial expression. Oh no, she wasn't talking about a baby. She was talking about a cat. By the time you figured it out, they're already talking about something new and now you're lost. And so I think that's, partially why people just say, forget it. I'm not even gonna pay attention. I'm gonna go think about something else. And if they really want me to participate, they'll get my attention and then maybe I'll re-engage. But yeah, it's subtle, right? It happens so subtly and slowly that a lot of people don't realize they're changing their behavior just because they can't hear as well as they once did. And that's hard to see. And sometimes hard for us to convince people that this is actually happening.
Mm-hmm.
Um, yeah. So getting back though to the cognitive testing element of this, I think there's a little controversy overall because I've heard some people say, well, cognitive testing isn't within the scope of practice of audiology. So why would audiologists even be talking about cognitive testing? And so what type of cognitive testing do you think as audiologists we could provide to patients?
Well, I
Is
like
there a
to
guideline there?
Yeah, well, and I like to differentiate between cognitive diagnostic testing and cognitive screenings. We're
Hmm.
well equipped to be able to screen individuals. And if that screening is positive, then we refer to other neurologists, psychologists, psychiatrists to do the in depth diagnostic testing. Um, but it's hard. Even primary care physicians, they just don't have time to do the screening. So audiologists, I mean, here at Sound Relief, our average new patient evaluation times are about 90 minutes, so we have a lot of time with our patients, versus going to a primary care physician for your annual testing when you have a lot of different things to cover. incorporating screening, cognitive screening in that is difficult. And our
Mm,
population base of adults and older adults for hearing loss is um, really the perfect population for testing or
right,
screening, I should
right.
say.
Right, because screening measures exist, like the mini mocha. I'm trying to remember some of the other screening tools that we can use, but they can be administered pretty quickly, right? I don't know, maybe 10 minutes
Yeah,
max
yeah.
in
Some of them
some
are
cases.
5 minutes, 4 to 5 minutes.
Right. And then again, it's not that we would be saying, "Oh my goodness, you have dementia." We would be saying, "Okay, this screening would indicate more testing would be appropriate. Have you spoken to your primary care physician about it at all? Do you have any cognitive concerns yourself? Is there any family history?" You're right. I think we are positioned better because we have the time. I mean, we see our patients on average. How many times would you say for hearing loss in the first year? How many times do we see a patient in the office?
Oh, about 6 times probably is.
Yeah. I think I factored that to be 6. So if we're seeing patients 6 times in the first year, and the reason that is right is because we are trying to help them adopt to new sound, new technology, the understanding how everything works, the why behind it, why it matters to wear devices every day, and to get into a routine, and because we have to hear well in quiet before we're going to hear well in noise. All of these things we have to really educate our patients in that first year, which is part of those 6 visits. So there's no way, I can't think of an example of why a patient would go see their primary care physician 6 times a year unless they're very ill. So the primary care physician just isn't having as many touch points to see possible cognitive issues, such as asking the same questions every visit, having to have instructions repeated multiple. All of us need things repeated multiple times, but if you have to have the same thing repeated 6 times or ask the same question 6 times in the first year, that's going to raise a red flag to us, right? Of like, is there something more going on here? And so I think, yeah, just like you said, we're just positioned to maybe recognize some of these initial cues that maybe some cognition is lacking, cognitive decline setting in. And we have the time also with maybe family members that are coming with the patient to the appointment to ask them, "Hey, are you noticing any changes here in your loved one's, ability to recall information?" And if they say, "Oh yeah, I have to repeat myself," at first you're not sure, is it just hearing or is it cognition, right? So talk to me a little bit about that, Dr. Harris, the complexity of if you have untreated hearing loss and you're trying to do cognitive screening, how the patient not being able to hear correctly the question could mimic cognitive issues when really maybe they don't exist. We're just talking about the fact that they can't hear the instructions to the test or to the screen.
Yeah, it's actually a bigger issue than I think people realize is untreated hearing loss and cognitive symptoms often overlap. And so, yeah, it's hard to know, is it a hearing problem or is it a cognitive processing problem? And even further with that is there's a lot of evidence that shows misdiagnosis of cognitive issues because there wasn't a hearing loss identified before. Because a lot of those screening and even the diagnostic tests are administered verbally. So when you're not catching all of the instructions, there can be a misdiagnosis of cognitive issues when it's really just an underlying hearing loss.
Right, which is scary, right? I mean, I don't want to be diagnosed with dementia if I just have, moderate hearing loss that I didn't realize needed to be treated. And I think people miss that overall or that general concept of if you mishear one word in the instructions given to you, you could completely answer inappropriately, right? It just takes one word in a sentence for you to miss, to totally have a breakdown in understanding,
Mm-hmm.
right? So it's not like, we're not even talking severe to profound hearing loss here. That would be maybe more obvious that, oh gosh, we can't do this screening because it's clear you have severe hearing loss. You can't even understand me at a normal volume. But I mean, tell me from your experience, have you met people with hearing loss that you were surprised by the degree of hearing loss that they had? After, what I'm getting at is sometimes I'm talking to people. Sometimes we're doing a case history. They're telling me what's going on, and I'm talking to them, and they're having no problem one-on-one understanding me in a quiet office. And then I take them to the sound booth and do a hearing test, and I think, holy moly, did you really hear everything I just was discussing with you? Because you have severe hearing loss. Have you noticed the same thing, or have you been surprised by how that can be missed?
Yeah, absolutely. Our brains are really good at compensating, and it's pretty amazing actually how well people can compensate even unknowingly, using visual cues, lip reading, trying to fill in the gaps with context. It's really quite amazing how often people can present with seemingly normal hearing and then get into the testing booth and we find a moderate hearing loss.
Right. Yeah, it always amazes me. And I think, wow, this person is working much harder than they realize to fully comprehend what people are saying to them. And no wonder they're exhausted by the end of the day. They've had to work so hard just to, like you said earlier, fill in the gaps or fill in those blank spaces of the missing speech, the missing words. It's fascinating to me. So I worry. Do you have the same concern, or do you have examples of this? Of, a lot of people will go see their primary care physician. You're in a very small room. It's quiet, and you're not more than a few feet from each other. And so even the primary care physician in the small office environment completely misses the fact that the patient has hearing loss prior to referring them to the neurologist for cognitive testing. And it's like, wait, step one should be, when's the last time you had your hearing tested, right?
Mm-hmm.
So
Absolutely.
have you seen that as well? And how do we fix that, do you think?
Yeah, I think just educating people about the risks of untreated hearing loss, and being more proactive in our healthcare, and being, even if you're not noticing significant hearing difficulties, step one is to get a baseline and get your hearing tested. So just being proactive and trying to educate people about the importance of it, I think is a big one.
Right. I think, having a hearing screening at a health fair is not really what we're talking about here. We're talking about, you need a comprehensive hearing exam in a soundproof booth that incorporates speech and noise testing, the full audiologic workup for us to really understand what's going on, for a confident baseline to be established. And at what age do you think that should be established? I mean, I think a lot of people are confused out there as to, well, should I be 70 when I get a baseline hearing test? Should I be 40? What do you think is something that we should be striving for?
Yeah, I mean, the earlier the better, because once you have that baseline, it's much easier to go back and see if there are any changes. And so even now our world is just louder in general. So we're seeing more and more damage to the auditory system just because our world's loud. And so hearing loss is showing up younger and younger. So, I think a lot of people, what I hear most often is people say, my last hearing test, I don't know, maybe when I was in 5th grade, maybe in school sometime. And unfortunately, that's the norm. And but getting tested, as early as possible, even in your 30s, coming in and getting that baseline, and then it's a lot easier in the long run to track any changes and stay on top of that.
Right. Because I know from my experience, gosh, the average age just keeps getting, like you're saying, younger and younger and younger. And I think it is. I mean, AirPods, all the Bluetooth headphones, headsets, 24/7, I really worry about our youth who have headphones in even to sleep. I mean, I swear some kids wear some type of a Bluetooth headset, I swear 24/7. And you just think they have no break. Their
Mhm.
auditory system gets no break whatsoever. So having that baseline assessment, trying to educate people about why the earlier the better, preventative measures to avoid damage, all these things are so important. And then trying to get the primary care physicians to understand we need a comprehensive hearing evaluation before we recommend cognitive testing to make sure that the hearing loss isn't contributing to the diagnosis of cognitive issues. Because I mean, I've seen it, I know you've seen it too. You, in some cases, you treat a moderate hearing loss with hearing devices, and it's like, and family members have even commented, it's like you gave us our family member back. This is how they were 10 years ago. Like, we should have been here 10 years ago to get this treated. We just didn't know what was going on. And although we love to see the transformation, oftentimes we wish that would have been years prior, right? Because
Mhm.
and in some cases it's like, oh my goodness, too little, too late. Why would that be? Why, for some patients that are finally acknowledging their hearing loss, finally motivated to get help, but have had hearing loss for untreated hearing loss for, let's say, 10 plus, 20 plus years, why are they not as successful with hearing treatment, hearing aids? What's behind that?
Well, and it's kind of similar to the to use it or lose it. When your brain doesn't have access to all of that sound and it's not getting all of the speech sounds, over time, the auditory cortex, the part of your brain that processes speech, deteriorates. And even if we give it perfect amplification, at all the frequencies where you need it, it's now more of a cognitive problem, auditory processing problem, more so than just a hearing loss that needs amplification.
Right. Yeah. And I think people don't appreciate the fact that when we're young and have perfect hearing, we have very narrow auditory filters in the brain to really process the difference, like I said before, between similar speech sounds like sat, fat, bat, cat. And when you can see someone who enunciates, you can use the visual cue to say, oh, I could see she said bat, right? But as we continue with aging and hearing loss, those auditory filters get broader and broader and broader, and a hearing aid cannot make the auditory filter narrow again. The only way to keep the auditory filters in the brain narrow is to give them the input they need so that they can keep the distinction and the word recognition abilities strong. So, yeah, the sooner the better. Like you said, you don't use it, you lose it. It's like a muscle, and the muscle's going to atrophy. But unlike a muscle, auditory nerves, any of our cranial nerves, we don't have a way to bring them back. We cannot recreate a healthy auditory nerve. We can only stimulate what's left. And I think that's really hard for people to accept. That, what do you mean? I only have 60% nerve function, auditory nerve function remaining. Yeah, because for 10, 20 years, that nerve just got weaker and weaker and weaker. And a hearing aid can't fix that, right?
Hmm. Hmm.
That's frustrating for a lot of people.
Yeah, yeah, and it is unfortunate because when people finally become motivated to seek treatment, it's um, it's never too late to seek treatment, but some of the damage is irreversible, and we just can't get that back.
Right, right. And then, I think people are getting more familiar with a cochlear implant, that whole concept. And a cochlear implant is really for those people who no longer have the connection between the hair cell, the auditory nerve, and the brain. There's been so much damage, so much distortion there that a hearing aid cannot fix the damage. So now we have to go to a more permanent solution that also essentially, um, how would you explain how a cochlear implant works with permanent nerve damage?
That's a good question. Basically, it replaces the auditory system, the cochlea, the hearing organ. It replaces it by you no longer get the natural sound stimulation, but it's an electrical stimulation. So it's a completely different way of hearing. Can be very successful, but it's really meant for people with that severe speech understanding scores where we, like you said, no matter how much we stimulate those hair cells in the cochlea, the word recognition just isn't there.
The reason why I wanted to bring it up, cochlear implants can still help with this whole concept of cognition and decreasing cognitive decline. So even someone with severe to profound hearing loss should not give up hope on being able to prevent some of these long-term impacts, because cochlear implants are very effective in regaining that connection and stimulating the brain, even though it is a different type of stimulation, like you're saying, electrical stimulation versus an auditory sound wave stimulation. But I think it's important for people to realize that we want to treat it early to try to avoid some of these long-term effects. But in some cases, with sudden total hearing loss that is irreversible, there are other options besides just hearing aids to help those people, and can help with cognition as well. So yeah, it's important to understand all these interconnections and how technology can help. But what's been the impression? What do you think of some of the current screeners, cognitive screening materials, or I guess, materials that we have available to us today as audiologists? Do you think a lot of audiologists are currently doing cognitive screening?
Unfortunately, no. I don't think a lot of audiologists' offices have started to implement that, and really, there can be some anxiety-inducing, some feelings and reactions to suggesting a cognitive screening that people are concerned about. So it's a hard conversation to have with people because there is a lot of insecurity about potential cognitive decline. So I think the conversation is harder to have, and I think that's why a lot of audiologists stray away from starting to implement that and implement the screenings.
Yeah, I would agree. Absolutely. It can be, if not approached in the right manner, it can seem, threatening. I don't know if that's the right word, threatening, but it definitely can be uncomfortable for sure if someone isn't maybe even ready to talk about it. That's why I think when family members bring it up, it's definitely easier, which is why we often request family members, a spouse, a loved one that's very familiar, maybe a loved one that lives with the patient, to attend appointments, to attend the audiology follow-up appointments, even to express their concerns about their loved one. But don't you think, at the end of the day, I do think, like many things in audiology, we need more training in our doctoral programs about the subject overall and how to offer cognitive screening effectively. I mean, so you're a recent graduate of University of Northern Colorado's audiology doctoral program. Did you have a class in this? Did you spend much time talking about cognitive
We
testing
didn't.
in
We didn't so much. I focused my research studies on cognitive decline and cognitive screenings, but at the time it wasn't in the curriculum. But I know that recently they've made changes to incorporate more cognitive screening education and why it's important for audiologists to understand and know even just the underlying link of untreated hearing loss and risk of dementia and cognitive decline. So I think it's slowly getting there, just not as quickly as I think that we could get screening measures out to people who need it.
Right. I think you're right. It's new. It's kind of a new topic area. I haven't seen necessarily all audiology programs adding it to the curriculum, but it's just like tinnitus, right? Most graduate programs don't have a lot of tinnitus in the curriculum as well. So that's frustrating. There's just so many, I think, subspecialties, if you will, within audiology that it's hard for sure to get some of these more specific areas covered. But there's a great need for it, obviously, and I think we can definitely strive to provide more education in the future in this area because it is so important, right? And I think that's the first step is if we learn it and we're confident in being able to provide it, we'll see it more readily available for patients to be able to benefit from. But it is a slow process, right? To get new concepts integrated into a curriculum. It takes time, and unfortunately, it doesn't get change does not happen quickly. Let's put it that way, I think.
Yeah. And at this point, there's no national recommendations for implementing screening in a clinical setting. So that's lacking. Audiologists don't have the guidelines at this point to implement that across the board. So.
Right. Yeah. Guidelines would definitely be helpful. And I know there's some equipment currently available. I looked at one that's called CogniView for a while as a cognitive screening tool in the audiology clinic. I know there's some audiologists that have incorporated into their practice well. In our practice, because of our focus with tinnitus, it was very hard to incorporate it, honestly. There just wasn't, like you're saying, there wasn't a easy segue to be like, oh, you're here for tinnitus and hearing loss. Let's also talk about your cognition. So it just wasn't an easy tool, in my opinion, for us to be able to incorporate at the time that it was just being kind of introduced. What have you heard about screenings like CogniView or any others when you were doing your research? Was there any
the CogniView is really a great tool because it takes the interpretation out of the picture. So a lot of screening measures, the concern is maybe the interpretation of the person administering the screening may not be clearly defined and the same throughout different interpreters. So the CogniView is really an objective way to kind of remove that potential factor, remove it. So it's really more of an objective measure. So the CogniView is really a great tool, and it's really simple and fast. So it's, in my opinion, that would be the one screening tool that I would use and implement.
Yeah, and I'm optimistic that we'll continue to see more options similar to CogniView being available because the one thing I liked, that I will say I really liked about CogniView, was there was no audio to it. There was nothing that the patient had to listen to. It was all written instructions on a screen. So the hearing loss component of cognition that variable was removed, essentially. The only difficult part about the CogniView, from my personal experience with patients, it had a joystick operation to the instructions, and it was on purpose that it was a joystick because it incorporated a little bit of motor skills, in my opinion, of could you just operate this simple dial that you had to turn either clockwise or counterclockwise. But for for younger generations that have grown up with technology and joysticks and video games or anything that has used any kind of a joystick, if you will, it was easier. But for my patients that were more elderly, 80 plus years old, that in and of itself made the task a little bit too difficult for them. And then I was wondering, well, is the task difficult because they're not understanding the task, or they can't conduct the task because they couldn't figure out this joystick? But I think that was on purpose, part of the assessment, but it was frustrating for some of my patients that I was kind kind of experimenting with this tool, honestly, to see what was going on. So I'm optimistic, though, that more options will come out in the future of similar design and similar overall presentation, like you said, that can be administered quickly. That could be something that we can say, hey, here is your report from this tool. Why don't we take it to your primary care physician and see if they would like to recommend further testing or not. So it's not difficult, right, in concept, but again, more difficult in explaining why we're doing this in the first place.
Absolutely. And I hope some of that will be remedied just by, I think more and more people are paying attention to hearing loss and cognitive decline and that link there. So I hope that conversation will get easier and easier as more and more people realize the implications of untreated hearing loss.
Yeah, I agree. I think it would make our job a little bit easier if people come in and say, I'm expecting you to do a screening on my cognition as well. Oh, fantastic. Here we have this machine right here. It takes less than 5 minutes to administer. Let's see what it says. And that would just make the whole conversation easier rather than us having to say, hey, we're concerned here. Would you be okay with us looking at this a little further? So we'll see how that changes, hopefully in the future, to make it easier and a standard part. It would be great if people just expected it to be a standard part of a hearing test, right? From an audiologist perspective, from a patient perspective, from even a primary care physician perspective of, hey, they can administer this easier than we can. We have 15-minute time slots for patients, whereas, like you said earlier, we're allotting a lot more time for discovery and testing and recommendations in our clinics. So it would make sense for us to be able to administer this in the future.
Yeah, and really just helping to close the gaps in cognitive monitoring and just promoting that collaborative effort, healthcare effort with different professionals, and just to get whole health for individuals.
Yeah. Right. Let's focus on being able to share information with each other for the best interest of the patient, because all of us, I would say most of us, all of us in theory have come to healthcare to help people. And so let's make sure we're doing the best job possible by covering everything, checking off all the marks to make sure we're not missing something as critical as memory, and making sure we're doing everything to prevent cognitive decline, right? As best as possible.
Yeah.
I agree. Awesome. So great. Let's switch gears for just a minute, because we want to end the podcast going forward with a little bit of Q&A of questions and answers from patients that are responding to our podcast or leaving comments for our podcasts. And so I want to leave with a question that was presented by a viewer of the podcast, and encourage people, if you have any questions about anything that Dr. Harris and I talked about today, please leave us a comment, a question, and we'll definitely cover it in our next podcast. We love to interact with our viewers and really give you the information that you're looking for, that you need. So this was a recent question left by Cosmo's mom. That was her name on the comment. And she asked, why is extended high frequency testing not regularly utilized? And just for our viewers that might not know what extended high frequency testing means, we typically test in a soundproof booth for a hearing evaluation from 500 hertz, that sounds like a foghorn, up to 8,000 hertz, that sounds more like a piccolo or flute, so low to high pitch. Why, Dr. Harris, would you answer this? Why do we not regularly test beyond 8 kilohertz when we know human hearing can go out to 20,000 hertz? Why would we not test that far?
Well, when we're testing for hearing, we're focusing on speech and communication. So speech sounds and come in within that range that you talked about, so under that 8,000 hertz. So extended high frequencies aren't really important for speech clarity and speech understanding. So it's not routinely implemented.
Right. We just haven't found clinical value necessarily in extending that frequency range out. And then also, I think a lot of people forget that by age 20, most people cannot hear 20,000 hertz anymore. So at a very young age, we start losing that ultra high frequency hearing ability. At age 30, most of us cannot hear at 16,000 hertz. And so the vast majority of our patients are coming in post age 30. So why would we test at frequencies we know, right, that are going to be missing anyway? So that's why. Although, when would we test in the extended high frequency range, Kelsey? Because I know there's times that we do. Why do we do that?
Monitoring for like chemotherapies, they tend to hit those extended high frequencies first. So chemotherapies we know can attack those hair cells in the cochlea. So monitoring, and then when we identify that it may be impacting those extended high frequencies, having that conversation with the physician, and do we need to change the dosage or the type of chemotherapy administered if it's starting to affect hearing.
Yeah, definitely. And then I've tested extended high frequencies or out to 20,000 hertz when someone presents with normal hearing and tinnitus. And usually those are younger patients, honestly. And sometimes we'll see the hearing is normal to 8 kilohertz. And then beyond 8 kilohertz, we see a typical notch. So noise notches, so where someone has had loud noise exposure, typically we see a decrease in hearing and recovery. That usually occurs around 4,000 kilohertz, where we see this decrease in hearing and recovering thresholds, better thresholds at 6 and 8 kilohertz. But for some people, that noise notch is out at like 10K, right? So if we don't look beyond 8, for someone with normal hearing and tinnitus, excuse me, we might not notice the 10 kilohertz notch, the 16 kilohertz notch with recovery at 20,000 if they were younger than 20, perhaps. So it does depend on age and symptoms, but I have done extended high frequency testing in those normal hearing with tinnitus patients. But again, that's not a typical protocol, but sometimes we need to do that. And also, you have to have special equipment to test out to that high of a range, right? We have to have special supra oral earphones or headphones that extend out to the higher frequency ranges, and our audiometers, our equipment has to be able to test out to that higher range. So that's why it's not regularly utilized, I guess is the best answer to that question. Yeah. Oh, sorry. And another continuation of this question: do the majority of tinnitus patients have hearing loss in similar ranges above 8 kilohertz, or can hearing loss anywhere on the range cause tinnitus? Was her second question. Can you answer that for us?
Yeah, absolutely. Anywhere on the range can cause tinnitus. So it doesn't have to be within those under the 8,000 hertz. Anywhere along the auditory system can impact and cause tinnitus.
Right. So occasionally I've seen some tinnitus pitch matches in a lower frequency range, like 500 hertz or 1,000 hertz, but that's typically not the norm, is it? I mean, what do you typically see as the most common pitch match for tinnitus in your
Definitely
experience?
high frequencies, 6,000 hertz, 6 to 8 are big ones.
Right. Yeah. Yeah, I would say I most commonly see 4, 6, and 8 kilohertz, or 4,000, 6,000, and 8,000 hertz as the most common pitch match, because if we break that down, right, if you look at the inner ear, the 2.5 coils of the inner ear, those high frequency hair cells are right at the entrance, the beginning, the start of the inner ear. And so those hair cells are the first to kind of get bombarded back and forth with loud sounds, right? So it makes sense that where we see the most damage to the hair cells is typically where we most commonly see the tinnitus pitch match, right? So it wouldn't make sense if someone had perfectly great low frequency hearing and a high frequency hearing loss to pitch match their tinnitus at a low frequency. Although never say never, because really the brain's generating this noise, right? But have you seen that ever, where they have high frequency hearing loss and a low frequency pitch match?
Not usually. It's not common. But
Right.
like you said, it does happen. The brain doesn't care.
Yeah. The brain's going to do what the brain's going to do, right?
Mm-hmm.
Yeah. And then last but not least, she asked, and can any of today's hearing aids help with extended high frequency hearing loss, say between 12 to 16 kilohertz?
No, not at this point.
Right. And again, I think it's just because it goes back to what you said earlier, that we're focused on the speech frequencies. People wear hearing aids to improve speech clarity because they can hear but not understand everything that's being said. And so the emphasis has not been on restoring frequencies that are not within the speech range, right?
Mm-hmm. Exactly.
Yeah. I mean, I think most hearing aids today still roll off. The gain starts to decrease past 8 kilohertz. The microphones are part of that limitation, right? They just can't. They're not. The microphones aren't capturing past 8 kilohertz. Although I think some microphone technology, I was reading up on it in preparation for this question. Some microphones do go out to 10 kilohertz, but I think too, wouldn't there be, I was thinking about it, I think there'd be a lot of risk of distortion too when you try to go too far out.
Yeah.
So that wouldn't be beneficial.
Mm-hmm.
We're looking for clarity and low noise floor and good sound quality. And so the microphone technology, I think, is probably the biggest limiting factor there. And I just can't really think of, excuse me, I can't think of a good why would we would want to chase those ultra high frequencies. Can you?
Yeah. I think, I think running the risk of distortion would be another hurdle for people trying to adjust to amplification. I can see it being more of a challenge at this point with limitations in technology of the microphones.
Right. And if there's no useful speech information, I'm trying to think what you would even capture at that high of a pitch with a hearing aid. So, but great questions, very interesting to think about. And like I said, we love the engagement. We love the viewers giving us comments about our content, and it's very helpful for us to know what do people want to know, what do people have questions about. So we would just encourage people to continue to bring us those questions so we can answer them on our next podcast. And I just want to thank Dr. Kelsey Harris here for her time today and for sharing her information and knowledge about the connections between untreated hearing loss and cognition. And I know we will have her back on the show again in the future to talk about even more topics coming up this summer. So thank you so much, Kelsey. Thank you for all that you do and for being here with us today. I really appreciate it.
Thank you.
Yeah. Okay. See you soon.
Bye.